Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
So this is a really nice schematic that shows the importance of molecular testing and why it's really important to wait. There seems to be an interesting relationship between the targetability of a mutation and what we call the immunogenicity, meaning how likely is it to respond to immune therapy versus how likely it is to be targetable. So on the far right here, we see mutations like ALK, ROS1, and EGFR. And we've long known that these are mutations that seem to be really effective when we use targeted therapies. But if you use immune therapy by itself, it produces very disappointing results. I would actually add RET, which is shown in the middle here, and move it closer to where we see ROS and ALK. On the left-hand side here where we have KRAS, so KRAS is an interesting mutation because we know that it is targetable. There are newer drugs out there now, a drug called sotorasib that can target KRAS G12C. But many patients who have this KRAS mutation will do really well with immune therapy or chemoimmune therapy. And so the reason it's important to wait on molecular testing is that especially when you suspect someone might have an EGFR, ROS, ALK, or RET mutation, is that there's higher risk of immune-related adverse events if you start with immune therapy and then you give targeted therapy. So this is a very common clinical situation. A never smoker, let's say they're 40 years old, shows up to clinic. We suspect they're going to have one of these mutations, EGFR, ALK, ROS1. But the molecular testing is taking a long time. And so the investigator will start them on immune therapy and chemotherapy together. The problem with doing that is that once the patient has received immune therapy and we realize that they have one of these targetable mutations, when you switch them to targeted therapy, they seem to have higher risk of side effects after having immune therapy before. So what I recommend is at a bare minimum, wait for EGFR, ALK, and ROS1. And I would also add here RET before starting chemoimmune therapy. Now it's okay to give the chemotherapy first while you're waiting and hold the immune therapy until you know the molecular status of the patient. So in summary, this was a broad overview of the importance of biomarker testing in lung cancer, some of the common testing methodologies and the limitations and trade-offs, understanding the biology of common oncogenes, and then recognizing the real world use of biomarker testing in lung cancer. And with that, I'd like to thank the audience for listening.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.